Welcome to this channel, where we provide educational content on medicine, pharmacy, and health to empower your learning and practice. Today, we're diving into another exciting topic in our pharmacology quiz series, Adrenoceptor blockers. This quiz will test your knowledge and reinforce your understanding of this critical pharmacological topic. Make sure to check out the companion video on this channel, which provides an overview of the main concepts of adrenoceptor blockers. The link to that video is available in the description below. Quiz instructions. This quiz will cover 10 multiple-choice questions, MCQs, focused on adrenoceptor blockers. Each question includes 5 options, of which only one is correct. After each question, we'll reveal the correct answer, provide an explanation for why it's correct, and explain why the other options are incorrect. So, let's get started. Question 1. Which of the following drugs is a non-selective beta blocker with additional alpha-1 blocking activity? Option A, bisoprolol. Option B, nebivolol. Option C, labetalol. Option D, esmolol. Option E, atenolol. The correct answer is option C, labetalol. The explanation is as follows. Labetalol is a unique non-selective beta blocker with additional alpha-1 blocking properties, making it effective for managing both hypertension and hypertensive emergencies. The alpha-1 blocking activity leads to vasodilation, further enhancing its anti-hypertensive effects. Here is the explanation for incorrect options. Option A, bisoprolol is incorrect because it is a selective beta-1 blocker with no alpha-blocking activity. Option B, nebivolol is incorrect because it is a selective beta-1 blocker with nitric oxide-mediated vasodilation, not alpha-blocking activity. Option D, esmolol is incorrect because it is a cardioselective beta-1 blocker used for short-term control of heart rate. Option E, atenolol is incorrect because it is a selective beta-1 blocker without alpha-blocking effects. Question 2. Which adrenoceptor blocker is most appropriate for managing a hypertensive crisis in a pregnant patient? Option A, labetalol. Option B, atenolol. Option C, pindolol. Option D, propranolol. Option E, metoprolol. The correct answer is option A, labetalol. The explanation is as follows. Labetalol is the first-line choice for hypertensive crises in pregnancy due to its combined beta and alpha-blocking properties, which effectively lower blood pressure without compromising uteroplacental perfusion. It has a well-established safety profile in pregnancy compared to other beta blockers. Here is the explanation for incorrect options. Option B, atenolol is incorrect because it may cause intrauterine growth restriction when used in pregnancy. Option C, pindolol is incorrect because it is a non-selective beta blocker with intrinsic sympathomimetic activity, which is not ideal in hypertensive emergencies. Option D, propranolol is incorrect because it is less commonly used in pregnancy due to concerns over fetal effects. Option E, metoprolol is incorrect because, although safer, it lacks alpha-blocking activity for rapid BP control in emergencies. Question 3. Which of the following is a selective alpha-1 blocker that is least likely to cause orthostatic hypotension? Option A, doxazosin. Option B, terazosin. Option C, alfuzosin. Option D, tamsulosin. Option E, phenoxybenzamine. The correct answer is option D, tamsulosin. The explanation is as follows. Tamsulosin is a uroselective alpha-1 blocker that predominantly targets receptors in the prostate and bladder neck, reducing the likelihood of orthostatic hypotension. It is commonly used to manage benign prostatic hyperplasia without significantly affecting systemic blood pressure. Here is the explanation for incorrect options. Option A, doxazosin is incorrect because it affects systemic alpha-1 receptors, increasing the risk of orthostatic hypotension. Option B, terazosin is incorrect because it has less uroselectivity, leading to greater systemic vasodilation and postural hypotension. Option C, alfuzosin is incorrect because it is less selective than tamsulosin and carries a higher hypotension risk. Option E, phenoxybenzamine is incorrect because it is a non-selective alpha blocker, commonly causing profound orthostatic hypotension. Question 4. A 40-year-old female is diagnosed with pheochromocytoma. Which of the following drugs should be administered before surgery to manage symptoms? Option A, phenoxybenzamine. Option B, propranolol. Option C, atenolol. Option D, metoprolol. Option E, bisoprolol. The correct answer is option A, phenoxybenzamine. The explanation is as follows. Phenoxybenzamine, a non-selective and irreversible alpha blocker, is the drug of choice for pre-surgical management of pheochromocytoma. It effectively reduces the risk of hypertensive crises caused by catecholamine surges from the tumor. Here is the explanation for incorrect options. Option B, propranolol is incorrect because beta blockers should not be given before alpha blockade to avoid unopposed alpha receptor stimulation. Option C, atenolol is incorrect because it lacks alpha blocking activity needed for pre-surgical management. Option D, metoprolol is incorrect because it is a selective beta-1 blocker unsuitable for pheochromocytoma management. Option E, bisoprolol is incorrect because it has no role in managing catecholamine-driven hypertensive crises. Question 5. A 65-year-old male with a history of benign prostatic hyperplasia, BPH, and hypertension complains of dizziness and fatigue after starting an alpha blocker. Which of the following adjustments is most appropriate? Option A, switch to a beta blocker like atenolol. Option B, reduce the dose of the alpha blocker. Option C, administer the alpha blocker at bedtime. Option D, discontinue the alpha blocker and prescribe an ARB. Option E, increase fluid intake to counteract hypotension. The correct answer is option C, administer the alpha blocker at bedtime. The explanation is as follows. Administering an alpha blocker at bedtime reduces the likelihood of postural hypotension and dizziness, especially in older adults. This adjustment helps manage symptoms without discontinuing effective BPH and antihypertensive therapy. Here is the explanation for incorrect options. Option A, switching to atenolol is incorrect because beta blockers do not address urinary symptoms in BPH. Option B, reducing the dose is incorrect because it might reduce efficacy in managing BPH and hypertension. Option D, discontinuing the alpha blocker is incorrect because it unnecessarily compromises BPH symptom management. Option E, increasing fluid intake is incorrect because it may worsen hypertension or symptoms of fluid overload. Question 6. In a patient with asthma, which beta blocker is safest to prescribe? Option A, propranolol. Option B, nadolol. Option C, atenolol. Option D, labetalol. Option E, carvedilol. The correct answer is option C, atenolol. The explanation is as follows. Atenolol is a cardioselective beta blocker with minimal effect on beta-2 receptors in the lungs, making it safer for asthmatic patients. Non-selective beta blockers can block beta-2 receptors, leading to bronchoconstriction and worsening asthma symptoms. Here is the explanation for incorrect options. Option A, propranolol is non-selective, blocking both beta-1 and beta-2 receptors, which can worsen asthma symptoms. Option B, nadolol is also non-selective and poses a risk of bronchoconstriction in asthmatic patients. Option D, labetalol has both alpha and beta blocking activity, but its beta-2 blocking effects make it unsuitable for asthma. Option E, carvedilol, similar to labetalol, blocks beta-2 receptors and is unsafe in asthma. Question 7. A patient presents with refractory hypertension and is prescribed a non-selective alpha blocker. Which drug is most likely prescribed? Option A, phentolamine. Option B, phenoxybenzamine. Option C, prazosin. Option D, doxazosin. Option E, tamsulosin. The correct answer is option B, phenoxybenzamine. The explanation is as follows. Phenoxybenzamine is a non-selective alpha blocker that irreversibly inhibits alpha receptors, making it effective in treating refractory hypertension, particularly in conditions like pheochromocytoma. Its long-lasting action helps in controlling blood pressure over time. Here is the explanation for incorrect options. Option A, phentolamine is non-selective but is used for short-term blood pressure control, not chronic hypertension. Option C, prazosin is selective for alpha-1 receptors, not a non-selective alpha blocker. Option D, doxazosin is also alpha-1 selective and does not provide non-selective alpha blockade. Option E, tamsulosin is used for benign prostatic hyperplasia, not hypertension. Question 8, which beta blocker is known to have vasodilatory properties mediated by nitric oxide release? Option A, bisoprolol. Option B, carvedilol. Option C, propranolol. Option D, nebivolol. Option E, atenolol. The correct answer is option D, nebivolol. The explanation is as follows. Nebivolol is a cardioselective beta blocker that uniquely stimulates nitric oxide release, promoting vasodilation. This additional vasodilatory property makes it particularly useful for managing hypertension with fewer side effects on peripheral circulation. Here is the explanation for incorrect options. Option A, bisoprolol is cardioselective but does not mediate nitric oxide release. Option B, carvedilol has alpha-blocking and antioxidant properties but does not promote nitric oxide release. Option C, propranolol is non-selective and lacks vasodilatory properties. Option E, atenolol is cardioselective but does not stimulate nitric oxide release. Question 9. A 45-year-old hypertensive patient with chronic heart failure is initiated on a beta blocker. Which beta blocker is most appropriate for this patient? Option A, propranolol. Option B, bisoprolol. Option C, atenolol. Option D, nadolol. Option E, esmolol. The correct answer is option B, bisoprolol. The explanation is as follows. Bisoprolol is one of the 3 beta blockers recommended for heart failure with reduced ejection fraction due to its cardioselectivity and proven benefit in reducing mortality and hospitalizations. It is initiated at a low dose and titrated carefully. Here is the explanation for incorrect options. Option A, propranolol is non-selective and not indicated for chronic heart failure. Option C, atenolol lacks strong evidence for use in heart failure management. Option D, nadolol is non-selective and not suitable for heart failure. Option E, esmolol is a short-acting beta blocker used in acute settings, not chronic heart failure. Question 10. Which of the following beta blockers also has intrinsic sympathomimetic activity, ISA, reducing the risk of bradycardia? Option A, atenolol. Option B, labetalol. Option C, pindolol. Option D, propranolol. Option E, nadolol. The correct answer is option C, pindolol. The explanation is as follows. Pindolol has intrinsic sympathomimetic activity, allowing it to partially stimulate beta receptors while blocking excessive sympathetic stimulation. This reduces the risk of bradycardia often associated with beta blockers. Here is the explanation for incorrect options. Option A, atenolol does not exhibit intrinsic sympathomimetic activity. Option B, labetalol has alpha and beta blocking properties but no ISA. Option D, propranolol is non-selective and lacks intrinsic sympathomimetic activity. Option E, nadolol is non-selective and does not have ISA. Conclusion. That wraps up our revision on adrenoceptor blockers. I hope you found this quiz session engaging and informative. To deepen your knowledge further, consider reading resources like Katzung and Trevor's Clinical Pharmacology, Rang and Dale's Pharmacology, and the British National Formulary, BNF. These references will solidify your understanding and enhance your preparation. Thanks for watching. If you found this video helpful, don't forget to give it a thumbs up and share it with others. Subscribe to this channel and hit the notification bell so you never miss an update in the series that we are doing. For more learning resources, check the description below. See you in the next video.